Welcome to this short video on anaphylaxis. This resource is aimed at undergraduate students, however anyone is welcome to watch. Let's get started. In this video we will be covering the definition, the triggers, how to recognize an anaphylactic reaction, how to manage this scenario, and what a patient needs upon discharge. So what exactly is anaphylaxis? It is a severe, life-threatening, generalized or systemic hypersensitivity reaction. This means that it is an allergic reaction that involves airway, breathing, or circulation compromise. In many cases, it is also associated with angioedema and urticaria, but not always. There are multiple things that can trigger an anaphylactic reaction. These include foods, such as nuts, fish and shellfish, eggs, cow's milk, and drugs, such as antibiotics and painkillers, venom from bee and wasp stings, as well as latex and contrast media. Occasionally, anaphylaxis can also present without an obvious trigger. And don't forget that those with severe asthma or rhinitis are more at risk of severe anaphylaxis. It is important to be able to recognize anaphylaxis quickly. It has a sudden onset with rapid progression of symptoms. Symptoms indicating airway compromise include persistent cough, hoarse voice, difficulty swallowing, and swelling of the tongue and the mouth. Problems with breathing can be indicated by stridor, wheeze, and persistent cough. Circulation compromise can be suggested by hypotension, tachycardia, pallor and floppiness, especially in younger patients, and altered consciousness can occur as well. Urticaria and angioedema commonly occur, but skin and mucosal changes alone are not a sign of anaphylaxis. Persistent gastrointestinal symptoms, such as abdominal pain and vomiting, may also indicate possible anaphylaxis. Respiratory symptoms are more common in food anaphylaxis in children, especially if they have a background of asthma. Diagnosis is also supported by exposure to a known allergen for that patient. Time is of the essence when managing a case of anaphylaxis. Use your A, B, C, D, E approach to assess the patient, to identify any airway, breathing, or circulation problems, and look out for any skin or mucosal changes which may aid your diagnosis. Always call for help early. Depending on whether you are in a community or a hospital setting, call for an ambulance or for the resus team. If possible, remove the causative agent, for example stopping a drug infusion, and lie the patient flat. If they are struggling to breathe, a sitting position may be adopted, which may make breathing easier for them. Administer intramuscular adrenaline, ideally into the patient's thigh. However, you can use any large muscle in the arm or leg. Adrenaline should be given at a concentration of 1 to 1,000, and the dose depends on the patient's age. Establish their airway, give high-flow oxygen, and apply monitoring. For example, monitor their oxygen saturations, cardiac activity with an ECG, and their blood pressure. If there is no response after 5 minutes, administer a repeat dose of intramuscular adrenaline and consider an intravenous fluid bolus. If, despite this, there is no improvement, confirm that help is on the way and follow the refractory anaphylaxis algorithm, which can be found on the Resuscitation Council UK website. Following an anaphylactic reaction, all patients under 16 years of age need admitting under a paediatric team for a minimum of 6 to 24 hours to observe for any biphasic reactions. Once this period is over, and they have been deemed suitable for discharge, consider whether or not they need an adrenaline auto-injector. If they do, make sure to provide 2 devices. You can find out more about when adrenaline auto-injectors are provided on the Beat Anaphylaxis website, but generally they are used if triggers are unknown or difficult to avoid. If they are a known allergy patient and they have used their auto-injector, remember to replace this prior to them leaving. They may also need other medications, such as antihistamines and steroids. Patient education is vital for effective long-term management and for prevention of future reactions. Educate your patient or their carer about how to recognize the signs and symptoms of both mild, moderate, and severe reactions, and how to manage this. Ensure a personal allergy action plan has been provided. Give advice on avoiding the trigger in order to minimize the risk of anaphylaxis in the future. This could include issuing leaflets about food labeling, for example. Always make sure your patient or carer knows how to use their adrenaline autoinjector. Demonstrate how to use one correctly and provide them with a trainer device so you can assess their technique. Remember to also show them how to check the expiry date. Provide any relevant follow-up advice. Notify them if they are being referred to a pediatric allergy service, and signpost them to useful resources such as Beat Anaphylaxis, where they can learn more about the condition. So let's recap some key learning points. Anaphylaxis can occur in the absence of skin involvement. Airway, breathing, and circulation problems are the cardinal features, and although urticaria and angioedema are often present, they are not essential for diagnosis. Anaphylaxis is time critical. Act fast and call for help early. Patient education is crucial for successful long-term management and for prevention of anaphylaxis in the future. You can find more information about allergy and anaphylaxis on the Beat Anaphylaxis website, as well as in the NICE guidelines. You can also find out more on the Resuscitation Council UK website, and find relevant patient allergy action plans on the British Society for Allergy and Clinical Immunology website. Thank you for watching this short video, and we hope you found it useful.